Hi class, this is our session on chronic inflammation, and this session will cover slide 77, chronic cholecystitis, slide 141, sarcoidosis, slide 143, silicosis, slide 148, TB, lung, and 177, asbestosis, 223, chronic sialadenitis. So take note of the spelling. Okay, and then when you are going to write the TB lung, make sure that you do not use the what do you call that, the dash. Okay, so TB lung. So some of the keywords that I would like to share to you would be the following. First is chronic inflammation. Then we have chronic cacheating granulomatous inflammation, chronic non-cacheating granulomatous inflammation, xerostomia, and keratoconjunctivitis sicca. So these are keywords which would mean that we may use this one during the exam, and these are very important keywords to take note of. So there's a difference between a cacheating, non-cacheating, and chronic inflammation. Okay, so let's start. So our first slide is chronic cholecystitis. So when we talk about chronic cholecystitis, this would refer to the inflammation of the gallbladder. So when you say chronic, okay, so the type of inflammation that we are going to state here would be chronic inflammation. Okay. So what do you mean by a chronic cholecystitis? It means that it has been present there for a long time. It may be due to the presence of several bouts of acute cholecystitis. In 90% of cases, it is associated with gallstone. But the inflammation present may not be directly associated with the stones, as in some of the biopsies that we have there can be an acalculous cholecystitis. When you say acalculous, it means that there's absence of gallstones, and still the patients would present with symptoms, and they would say that it may be due to supersaturation of the bile. Okay? But 90% of cases, again, it is due to stones. Okay? And bacteria can be isolated, especially the E. coli or Escherichia coli and Enterococci. So what would be the appearance of the wall? It is thickened. So this is a thickened gallbladder wall, and the lining epithelium of the gallbladder wall would be a simple columnar epithelium. Okay. What do you see here? There's a lot of inflammatory cells, okay, in the lamina propria. So what are they? So they are of chronic inflammatory cells consisting mainly of lymphocytes. I see this one is a plasma cell there. Okay, and then the rest are lymphocytes. Okay. Um, and then if we're going to look at the other areas, let's try to see on the other side. Okay. So there might be outpouchings of the gland. Okay, but it's not present in this particular slide here, like this one. So there would be the invagination or outpouching of the mucosa or mucosal glands going into this would already be the smooth muscle layer. If it invaginates or it goes down deep into this area, we call this as Rokitansky-Askov sinuses. Rokitansky-Askov sinuses. Okay. Uh, I think I have seen some segmenters in the area, like in this case. Okay, so notice This one would show um, the sloughing of the lining epithelium. So it means that this is ulcerated. You can see some segmenters already. Okay, let's try to identify them. There. So you can see some segmenters present there. So this would be evidence of exacerbations, or in the case if this would contain the stones, the ulcers can be caused by the presence of those gallstones. Okay, so again, this is chronic cholecystitis. The type of inflammation would be chronic inflammation. Okay, next is 141. This is sarcoidosis. Okay, this particular slide would be coming from the lung. So this is 141. We have the alveolar spaces and alveolar walls. This is sarcoidosis 141. And sarcoidosis is a type of condition that would be associated with chronic non-cascating granulomatous inflammation. Non-cascating, so chronic non-cascating granulomatous inflammation. So sarcoidosis is a condition that can be associated with autoimmunity. So there is disordered immunologic regulation that is seen in susceptible or predisposed individuals. So what happens here is that there seem to be proliferation of CD4 cells, T cells, okay, as compared to the CD8, and they have a ratio of 5 to 15 is to 1. So there is a difference. And the reason for the T cell expansion here is attributed to the interleukin 2. If it's the macrophages that would be uh, present, proliferating, it's the interferon gamma. Okay? So if it's what would be the reason for the T cell expansion? Like in this case, we have T cells surrounding this area. It's associated with interleukin 2. But if it's the macrophage that would be activated, it's the interferon gamma. Okay. So what do you mean by the macrophages? The histiocytes. Okay. So the most common site for sarcoidosis would be the lung. So this is the slide. And then we have the lymph node. So for lungs and lymph node, it's 90% of cases. And then we have the eye and the skin to be the other organs that would be involved. Again, it's a chronic non-cascating granulomatous inflammation. So in the lung, we would see the presence of these nodules. You can see that it's not common. So based on histology, you know that the presence of these nodules would not be common in this area. Okay, okay, so let's try to see what's the problem here. Okay, so this would be a granuloma. And a granuloma would be composed of cells that are activated macrophages. So what activates these macrophages? Interferon gamma. What activates the T cells? Interleukin 2. Okay. So you can see the presence of this footpad shape, a cells that has footpad shaped or sandal shaped vesicular nuclei. This one also, and moderate cytoplasm. So these are what you call as the epithelioid histiocytes. Why are they called epithelioid? It's because when you say epithelial, that pertains to an epithelial cell. But if you are referring to something similar, that's what you call as epithelioid. It mimics, it looks like, okay? And then you also have the presence of these giant cells, which we would call as the Langhans type giant cells. Okay. So it's actually a fusion of several epithelioid histiocytes. Okay. So next we have slide 143. This is silicosis. Okay. Silicosis is uh, a type of lung disease that is caused by inhalation of silicon dioxide or silica. So this is an occupational disease wherein it is common in people who are exposed to sandblasting. Sandblasting is a form of repair for rusty ships. Okay, so they do sandblasting. It is also common among stone carvers because of the release of silica, jewelers, and road builders. So the silica crystals that would be inhaled would activate the inflammasome, which leads to the release of interleukin 1 and interleukin 8. And notice in the slide, you would see a lot of this black pigments, okay? So which is indicative that this particular person has been exposed to carbon. So it means that this is a minor. Okay, so it has a lot severe anthracosis. Okay, but that's not the silicosis part. Okay, so the silicotic part here would be this one. Okay, so the type of inflammation here is a chronic inflammation, and the silica, it's not readily identifiable in this case. Okay, what we see here would be silicotic nodules. These are silicotic nodules composed of dense collagenous tissue. Okay, so it's composed of dense collagenous tissue. You won't be able to appreciate the silica. Okay, so it would require a polarizing microscope to elicit a weak birefringence on this case. Okay, so this is silicosis, and this is chronic inflammation. Okay, next we have slide 148. Okay, so slide 148 is TB of the lung, okay, or TB lung, okay, TB lung, or tuberculosis, okay, so that you will not have any difficulty with regards to VSA. Okay, so TB of the lung or tuberculosis of the lung is identified with a chronic cacheating granulomatous inflammation. Chronic cacheating granulomatous inflammation. So where do we see the granuloma? Okay, it's the nodules that are seen within the tissue. So you see a lot of those nodules there. And then uh, we would see larger nodules, okay, here, here, here. So there's a lot of nodules in this particular slide, okay, a lot of nodules. There, you can see a lot of nodules. Okay, there, there, okay. So the nodules would contain this uh, amorphous, pink amorphous material there at the center or at the outside, okay? And this pertains to the caseous necrosis. So this is the caseous necrosis. You would see some remnants of the nuclei, which you would call as the basophilic stipplings, okay? And then these are the activated macrophages, okay? There. So these are the epithelioid histiocytes or activated macrophages. These are the Langhans type giant cell, Langhans type giant cell, Langhans type giant cell. So do not write the apostrophe. Okay, Langhans, Langhans. You just write Langhans. Okay, Langhans type giant cell. So this is caused by Mycobacterium tuberculosis. Then we have slide 177. Slide 177 is asbestosis. So it's a condition. Actually, this may be an occupational hazard or occupational due to occupational exposure, or this can be due to exposure to the home. Okay, so asbestos is uh, is a it's a material that has been used as an insulator during the old times. So it has been used in construction. And asbestosis would be associated with inhalation of this crystalline hydrated silicates, which we would call as asbestos. Okay, so we would see the presence of the alveoli, alveolar spaces. Notice that the interstitium appear to be thicker. So there's interstitial fibrosis noted, and the type of inflammation, okay, that's present here is chronic inflammation. Okay, so again, as you can see, there would be thickening of the interstitium. Okay, it's thickened because of the presence of fibrosis. And then you see presence of inflammatory cells. So the type of inflammation here would be chronic inflammation. So what causes the inflammation? So you have to look for the asbestos bodies. So what do they look like? There. There. Okay. So those are the asbestos bodies there. Okay. So the asbestos bodies appear to be golden brown beaded rods. Okay. So they contain the iron proteinaceous material. So again, type of inflammation would be chronic inflammation. Okay. What would be the um, histologic feature present in these areas? That would be interstitial fibrosis. Okay. And then the presence of asbestos presence, then this is asbestosis. Okay. Last slide is slide 2 to 3. 2 to 3 is chronic sialadenitis. Okay. So the chronic sialadenitis would refer to the inflammation of the salivary glands. It can be associated with autoimmune disease called Sjogren's syndrome. It can be associated with trauma. It can be associated with a viral infection like what's the most common? Mumps or bacterial infection. Okay. So what you would see here would be the presence of the okay, so you have the presence of the serous acini, okay, some fatty tissue. Let's look around first. You have here the fats, adipocytes. Okay. Some areas are not so good. Okay. Okay, so this area would show the presence of these acinar structures there. Okay, so those are serous acini. Let's try to look at this one again. Okay, so that you would appreciate. So you have the serous acini, and then seen in some areas would be the presence of dense numbers of lymphocytes. Okay. Sometimes they would surround these ducts. Okay, here you have the ducts, and sometimes it would occlude the ducts, causing retention of the saliva. Okay, so and that will lead to the absence of saliva within the mouth, which we would call as xerostomia. Dryness of the eyes would be keratoconjunctivitis sicca if it is a Sjogren syndrome. Okay, so if it's only the saliva or there's inflammation of the salivary gland, then it's only the xerostomia. Okay, so that's the last slide that we have. So make sure that you study. So thank you and good day.